This is Health Yeah, your weekly update on what's going on in the health, wellness, and medical world with Monica Robbins.
Hey everyone, thanks so much for tuning in to Health Yeah, your prescription for clear, concise medical health and wellness information. I'm Monica Robbins. Full disclosure, in October of 2019, I had a craniotomy to remove a benign meningioma behind my left eye. I still have residual tumor left over back behind my eye, in my eye socket, on my optic nerve, and on my carotid artery that still needs to be monitored every 6 months with an MRI. So today, we're going to be talking about brain health and brain tumors because June is Brain Awareness Month. And who better to help me do that than my own neurosurgeon, Dr. Pablo Recinos from Cleveland Clinic. Thanks so much for joining me.
It's a pleasure to be here with you and your audience today, Monica.
So we've got a lot to get through. So let's start with one of the biggest misconceptions about what a brain tumor is. They're not all the same, right? Can you explain the difference?
Sure. Yeah. Everybody, when people get diagnosed with a brain tumor, as you well know, it can be a very emotional thing. But this is where we come in and really evaluate the symptoms that people have and the imaging. And some tumors arise inside the brain, some tumors arise around the brain, some tumors are located deep within, others closer to the surface. And they are certainly not all the same. Some of the brain tumors can be cancers and have a very aggressive course and are treated with a whole wide range of therapies up front. Others may have a more benign course, benign meaning that they're not cancerous, and slow course. So really we take all those, take the combination of patient symptoms and why they presented in the first place and look at their imaging before we make a decision on how we recommend them to be treated.
So are all brain surgeons the same?
No. Certainly, I think within the Cleveland Clinic, I'm very fortunate to work with an outstanding group of colleagues, and we have slightly different areas that we specialize in. So some of my colleagues will specialize more in tumors inside the brain tissue. Many of those are brain cancers, but not all. They will use techniques, for example, as doing surgeries awake. They will map the function of the brain. So, and in order to be able to do the safest surgery that's possible in those cases. I do a lot of skull-based surgery. So this is primarily for tumors that arise at the where the brain space meets the nose or meets the spine. Many of these tumors tend to be benign, although not all of them are, and the considerations are different. Maximizing the amount of tumor that we can remove, but at the same time having a very critical focus on maintaining the quality of life of the patient, minimizing the amount of complications that we can get, whether it's from vision, from eye movements, from sensation to the face, hearing, etc. So there's, of course, brain surgeons that do a lot of a varied practice, but I think when you get to places like the Cleveland Clinic, you see people tend to become super specialized.
Let's talk some statistics. How common are brain tumors, and is one type more common than the other?
Sure. So first of all, over 700,000 Americans are living with a brain tumor today, and more than 84,000 people will have been diagnosed with a primary tumor in 2021. I mentioned just some general categories, but there are up to 120 different types of brain tumors. So to your point, not all of them are the same.
What are the most common brain tumors that you see?
Yeah, so the most common brain tumors that I see are meningiomas, which overwhelmingly tend to be benign, although not, a small percentage of them can be more aggressive. I see tumors that involve the pituitary gland. The pituitary gland is known as the master gland. It's like I tell people it's the foreman on the work job that does work, but it also tells a lot of other glands in our bodies to do work. And so tumors can arise from there. Out of all of them, meningiomas are the most common. Glioblastomas, which are tumors which arise inside the brain, are and they're brain cancers, quite aggressive brain cancers, which are the second most common type of tumor.
Are all tumors potentially deadly?
Yeah, that's a great question. Even tumors that are benign, so ones that are not considered, certainly I think we would all understand that tumors that are cancers can be deadly. I don't think that that's hard to understand. But tumors that are benign can also be deadly if they grow in a very deep location and they start pushing on important tracts, nerve tracts. So for example, an area called the brainstem, which I tell patients, this is like your super highway, which connects your upper and lower brain to the entire rest of your body. If you start pushing that and the fibers that are a part of that start becoming blocked or squished, the way that people walk, eat, talk can become affected. And likewise, treating them, especially ones that arise quite deep and that are perhaps really stuck to that area, even though they may be benign, they can lead to somebody having a shortened life expectancy. Or even some of the treatments have to be very well carefully thought of, because being overly aggressive or simply having a complication that can happen can result in somebody living less.
So I would guess another misconception then is about symptoms. I mean, you know that my symptoms never correlated with a brain tumor. I had what I thought was eye swelling and eye tearing constantly. I thought I had severe allergies. So never in a million years would I think I had a brain tumor. But can you discuss the variety of symptoms and when should people go see a doctor?
You mean the allergy medication didn't work for you,
No.
Monica?
Couldn't figure out why. No, yeah, that's and thank goodness for my allergist who told me, allergies don't happen in one eye, so that's how I ended up in your office.
The funny thing about that is, for example, with meningiomas, something that the tumor that we tackled together and that we continue to monitor. If you Google meningioma, you're going to find every symptom under the sun that's there. But the way that I explain it to patients, and this is why it's sometimes a little complicated to research, do your homework, but without having any context behind it. With meningiomas, it's like real estate. It's location, location, location. So in certain areas, I would expect someone to develop vision problems, even with a small tumor. In other areas, I would never expect vision problems, but may expect hearing to be affected, or the way that swallowing happens, or perhaps some weakness. And just as you wouldn't expect for your house to need hurricane insurance or to be damaged by a hurricane if you don't live near the coast, the same is true with meningiomas, that there are certain symptoms that you just simply would never expect, even if they would grow to a very large size. And this is where we as physicians help our patients, guide them and help them understand what symptoms may arise when they do have it. Now, a story that I hear quite a bit is a story that may be like yours. I had my eyes tearing, I had allergies, the allergies aren't going away, or sometimes people get their head scanned and for headaches, or they were in a car accident. So these are all common reasons which we now find them. But that context has to be weighed out in terms of what is found, whether it's even related or not.
So are a lot of brain tumors found by accident? Like mine, I had a CT scan to rule out what they thought was a thyroid condition. So is it typical that you find a brain tumor because you're looking for something else or trying to rule something else out?
I think that it really depends on the type. So for example, if something grows really slowly, then sometimes people don't pay any attention to symptoms they may be having, and even some of the symptoms that may develop may look like something else, may look like allergy problems, may look like so I've had other patients that with very large meningiomas that affected the frontal lobes, where they thought, okay, I'm in my 70s, I'm starting to lose my memory, maybe get a little grouchier, a little less organized. And yes, of course, that can be something that can be associated with dementia or aging, but it can also be associated with benign tumors that are growing slowly and really affecting the way that people's thought process works. Cancerous tumors, on the other hand, I'll say tend to present a little differently. For example, a person can have a seizure or a sudden onset problem with speech in a course that's relatively shorter because they grow faster.
It's interesting you say that, because after I was diagnosed, when I looked back, I think I had far more symptoms than I realized, especially with, emotion, because mine was in my left, hemisphere frontal cortex. I thought, I was having memory issues. I was having some other things, but everything I had, it was easily written off as something else.
The problem is you're not busy, right? It's not like you're not a busy person. You're super busy, right? So, and when we're super busy, we're going to be sometimes forgetful or stressed, or I'm not sleeping well. All of those things can also be reasons. Right?
Yeah, everything was so easily written off. And that's the thing with, I tell people, if you're having a headache that's lasting longer than a week, you need to get to your doctor. Are there any other obvious symptoms that, or maybe not so obvious symptoms, that people, if they notice that are, a symptom that is prolonged, it's not going away, maybe it's getting worse, but then it gets better? Is there anything that, should be that red flag? Obviously, if you're having a seizure, that's, we understand that. But with meningiomas, they're sneaky. And so is there anything you would suggest, like, hey, you know what, you should go get this checked if you're experiencing X, Y, or Z?
The challenging thing with answering that question is that there's so many different symptoms that can show up, whether it's vision issues, whether it's memory issues. Sometimes particularly with pituitary tumors, people can become very fatigued, have changes in heat or cold intolerance, for example. I think the important thing is maybe a couple messages that I would give is, first of all, if you're having symptoms that are just persistent, that you shouldn't ignore them, which is what you were saying. If you're having headaches and they're just new, and I don't normally have headaches, they're not going away, probably means that somebody should evaluate you. And then the second thing is, because not everybody's in tune to thinking there's a tumor in your head, and with certain things, it may not be the most common thing. If you go in and your complaint is fatigue, or your concern is fatigue, the first thing that's not gonna happen is to get your head scanned, right? They're gonna check some blood work and look at your thyroid and some other things. But if in the end things aren't just checking out, to be empowered, for patients to be empowered to say, look, are there other areas that we need to look at? Do we need to look at my head, for example, as a potential cause? I heard this might be a possible area.
I'm glad you brought that up, because I was one of those patients who, for, really the first time, was my own best advocate. Because I was having this problem for over 2 years, I kept, I saw my allergist every month for my allergy shots. And I, would bring up to her, hey, this is getting worse. Is there anything stronger? And, if you don't open your mouth, you really do have to say something. And in most cases, not everyone's going to be diagnosed with a brain tumor, but, you really do need to check things out. And one of the things that I would recommend not doing is just jumping on the internet and searching for whatever. I'm fortunate. I'm the health reporter. I actually knew where to go and what to look for. I knew I had a mass behind my left eye. I didn't know what it was, but I knew where to go and start looking for information. But I remember sitting in the office with you, or the exam room, for the first time, and the first thing out of my husband's mouth was, I told her not to Google. And you know what? He's not wrong. So not everybody is a health reporter, but can you talk about the advantages and the dangers of just jumping on the internet and trying to get the information you think you need?
Absolutely. And I'm both a physician and surgeon, but I'm also a person, right? So, if I've had anything for myself or family members and it's perhaps a little bit out of my area, what are the things that I tend to do? I go look things up. I think it's a natural impulse for everyone to do. So I'm not, what I don't do is I don't discourage people from, I don't say don't ignore the internet altogether, because that's just not realistic. But I do think it is very important for people to any information that they get and how they process it, for them to share and interact with their physician as a partner, because that physician can add that context to what it is. So I may tell you, yeah, I saw that I know that you have the question about urinary incontinence and meningiomas. This is completely not applicable to your case, because the location of it is not going to affect that function for you. And so I think it's good when patients act as their own advocate. And a lot of times that moves things forward a little bit, but at the same time, if it's important for them to share those impressions with their doctor, so that appropriate filter can be added to it. I think it also gets complicated when people are so sure that this is the cause of what's going on with me. I read a lot about this rare disease, which occurs in 1 to every 1 million people, and this is exactly what's happening with me. And it is very disappointing, and sometimes really almost difficult to believe that when people get an evaluation and then you start saying, actually, this is not what I think is going on with you, because they're very sure of that. So again, I think that just to summarize, I think that information is great. I think knowing where reputable sources of information, such as the American Brain Tumor Association, those are very helpful resources, and then to communicate with your doctor to really process that information.
What about social media? Because that was one of the things I did, was, went on Facebook, and of course there were a zillion brain tumor groups. And one of the most difficult things for me was I went into some of these groups, and they were worldwide, and they had over 5,000 people in these groups. And the first thing I did was search for my particular type of tumor, which was a sphenoid wing orbital meningioma. And there were only 6 comments about my particular type of tumor. And then I started reading everyone's experiences, and it just scared me senseless, because, a lot of times I think people forget, sometimes those groups are where people go to complain. And every once in a while you'd get a happy story, but it was a lot to process. Do you have any advice for people before, because this applies for any health condition? I think these things are good, but I think it's really important to keep them in perspective. Do you have any insight that you can share about, what people need to remember when they go to these sites?
Out of curiosity, Monica, did you find information that, in retrospect, knowing what you know today, was helpful?
No, I didn't. I wished I did. And I have since. I'm still members of these groups, and I still jump on every once in a while because I'll get a notification if somebody posts. And if it's something I might be able to help answer, will comment. But I tend to try and make my comments a little more positive because, let's be real. When you're told you have a brain tumor, your world stops. And
absolutely,
it's one of those things where you just try to figure out what's next. And the other thing I learned was there are so many different types of brain tumors and surgeries for that matter. It's really hard to compare apples to apples in most cases. Even if two people have a GBM, one could be in one location, another could be somewhere else, and the symptoms are different. So can you talk a little bit about that?
Sure. So I can maybe just give some different perspectives, both positive and negative to that. I think one of the biggest things that you point out is I was diagnosed with a brain tumor. I want to know if there's other people that are going through or have gone through what I'm going through now. It's a whirlwind, right? You can speak to that experience better than I can, and you just don't want to feel alone. That you have somebody who has dedicated a certain amount of time in a consultation, and that probably wasn't enough time for all the things that are going through your head. And so it's totally natural to want to reach out and engage with other people who have been through what you're going through. It's complicated because you pointed out one of the big problems. Some of the biggest voices are some of the people who have gone through problematic courses, maybe really complicated courses, and ones where the outcome was not good. And that can really affect what your impression may be. You may be leaning towards surgery. You may be with somebody who has a lot of experience and may have discussed the risks and benefits of treatment, and then all of a sudden be scared off. And little did you know that the person that you're engaged with online went to somebody who doesn't deal with that problem very often, had a really bad outcome, is really impaired because of it, and disappointed. And if that's the only perspective you get, that may impair your ability to make a good decision in that case. On the other hand, this was sort of the pre-internet, pre-Facebook group solution. Some of the things that we would do and still do is pair patients, if they wish, with other patients who have been through similar problems that can walk them through, what the process is like, what it's like the day of surgery. And there are various support groups as well. So I think, unfortunately, there's no exact filter to say this Facebook group is good and this one maybe not as good. For certain rare tumors, take chordomas, for example. Chordoma is a very rare tumor. And there are, the Chordoma Foundation is an excellent resource to help guide patients through that. And it was started by a patient, and it's a more formal foundation. But that is they have sort of well thought out resources for people. So, but it's really tough because so many people are on social media. So many people are looking to make sure they're not alone, as I'm sure you were, right?
Yeah, initially, I'll tell you, when I went public with my diagnosis, and especially even now, I just had a call last week. when people are diagnosed, now I'm a resource. So I'll get emails and I'll get phone calls from people. And one thing I learned is I don't share my particular type of tumor story, if you will. What I found was most useful was what to expect when you're in the hospital, what to expect from, the surgery. I can't speak to everyone's outcome, but I can tell you, hey, look, unless you pass PT and OT, they're not going to let you out, and kind of give people at least a little insight as to what to expect after surgery. And there's always going to be before brain tumor and after brain tumor. Your life completely changes no matter how you look at it.
It sounds like you've evolved in how you are in terms of giving your perspective and counseling. As a pseudo lay person, I'll say, because obviously your job is as a medical reporter, but
I think it's important for people to know, hey, these are things you can expect, like my hair loss. We never discussed that. I had no idea. I thought, the big thing was you weren't going to shave my head. That was awesome. But little did I know that just head trauma, any kind of head trauma can cause hair loss. And that was something, I shared with a lot of people, wasn't expecting it to happen. And that's the issue, is that it does happen in some people, but it doesn't happen in everybody. And I think that's so important for people to understand that, hey, just be prepared. If this happens, this is, what you can do. And if it doesn't happen, good for you. So, I think those are, other things that people need to keep in mind. Let's move on to surgeries. You perform a bunch of different types of surgeries, and I still tell people, I had a craniotomy, which is I'm guessing one of the most invasive types of surgeries that you would do. I'm still proud of the fact I wore out 2 6-millimeter drill bits because you was much into my skull. In fact, I wanted to go to Home Depot and find 2 6-millimeter drill bits and mount
put them on the wall.
Yeah, put them on my desk or something as a paperweight or something. But kind of talk to me about, not everybody has to undergo the type of surgery I did for meningioma. Can you talk about the different types of surgeries and how do you know what's better for one and not the other?
Sure, happy to cover that. So a craniotomy just means making an opening in the skull, and a traditional craniotomy or traditionally craniotomies have been bigger, right? And as you alluded to, we would start out by shaving somebody's head, right, half of their head, and then making these big openings. But as time has gone on, we've learned to be less and less invasive. The most important thing in deciding with options that are bigger, let's say, versus smaller or quote unquote less invasive is, can we still accomplish the same goal as safely and as completely? And if the answer is no, then we should probably be doing something, more open or more extensive. There are several techniques that have really evolved over the last, I would say 15 to 20 years, and even significantly over the last 5 to 10 years. Procedures, there's certain tumors that are very accessible by going through somebody's nostrils, and the technology has evolved amazingly in this area. So we can insert almost like little telescopes called endoscopes into the nose. And I do a lot of these procedures, for example, with my rhinology colleagues. And we can take tumors out that are sitting underneath the brain, or even accessing things like some spinal deformity that is now pushing on the upper spinal cord or the brainstem and causing somebody to become weak, all by going through the nose in a way that saves you from any incisions or scars on the outside. There are ones that fall into the category of craniotomies but are less invasive. So we'll do incisions in someone's eyebrow or eyelid even. And some of those scars are very difficult to see. The craniotomy in those cases may be less than an inch, or a couple centimeters, and we can still access what we need to. For some deeper areas, looking at either tumors inside the brain itself or just deep, we now can use tubes, for example. These small tubes, which the idea is that they'll split in between some of the fibers to minimally traumatize the brain tissue, and be able to look around and take out these very deep tumors that lie inside the brain. And some of those are amazing, that people can be ready to go home even the next day from what would have been required, a 7-day stay, extended rehab. And now, even though we're going through some of the brain tissue, just very minimally disruptive. So lots of exciting technology. Laser, treating tumors with lasers, for example, where we just insert a little cannula, like some of my colleagues do, those are all techniques that can be used. But again, they're tailored to each different situation. So in the end, can we accomplish the same goal by being less invasive, or perhaps accomplish it better by being less invasive? If the answer is yes, then those techniques are great.
So talk to me about, why are women more prone to meningioma, and why is gender actually a factor that's being studied relating to brain tumors in general?
Sure. Well, it's not hard to say that men and women are different, right? We know that. With meningiomas, it's been thought that there is some hormonal implication, or something about the environment that changes your likelihood to get one of these tumors. Hormones, particularly progesterone and estrogen, are obviously in higher amounts in women. And do those play a factor? The answer is likely yes. But what is the exact factor? This is where it gets tricky, and it's hard to answer this question. I get asked questions, for example, okay, I've been diagnosed with a meningioma. I am on hormone replacement therapy. What should I do with this? And we don't have great data, I would say. For a while, there were certain combinations of hormonal replacement therapy that were suggested to play more of a role in growth, and then other data came out and it's been refuted. So we don't entirely fully understand the why that's the case. We're starting to learn in some of the brain cancers, and this is, for example, work that Dr. Justin Lathia here at the clinic is looking at, sex differences in glioblastoma, and just starting to begin to understand that there might be some differences in that tumor environment, or the way somebody's immune system is working, that may be different between men and women. This may be something also at play within meningiomas, but we really need to do more research in these areas to figure out the why. And obviously, when you understand the why, then you can start acting upon them.
I know when you and I sat down and did our surgical plan to come up with how we were going to deal with my tumor, I think I knew from the very beginning that you weren't going to be able to get all of it, that I was going to have residual tumor left. How do you determine what's going to be a problem tumor that will require future treatment? Because not all of them, I guess when people think of tumors, they automatically think they're just these perfect little golf ball things that are stuck in your head. And unfortunately,
wouldn't it be nice if they were?
Yeah, I wish mine was, that's for sure. Would have been a lot easier, but mine was just a hot mess of a pancake, like splattered batter, I guess. But how how do you know ahead of time? Is it just from imaging? And how do you determine like what your surgical plan and then aftercare plan would be?
Sure. So I think it's all the surrounding structures and how the tumor is interacting with those structures. If it's something that's around the brain, like in your case, we look at the important things that we want to make sure that we preserve: your vision, your ability to move your eye well. Those are probably the most important things that we considered in a case like yours. And if I look at something on imaging and there's a part of the tumor that is going to be too high risk, because either you'll lose your vision or we can affect a critical artery that could lead to a stroke, particularly with something that is not cancerous. And we also have some backup treatment options like radiation. Then we will just plan and understand ahead of time that we need to leave a little bit of tumor behind. If it's even with brain cancers, I think that the same amount of planning goes into those cases. If a brain cancer is involving somebody's speech area, and you know that ahead of time, but their speech is still pretty good, then it may be something that either the surgeon decides to do the surgery awake so that they can in real time map somebody's speech, or they will just upfront understand that the goal will be to get most of the tumor, but not all the tumor necessarily, to avoid causing a new major problem that can dramatically impact somebody's quality of life. So I think it's just weighing out what structures are around the area in question and how they would impact somebody's quality of life, and is that going to change the overall outcome, and at what cost.
What is CRISPR?
One of the hot topics right now is in immunotherapy, looking at somebody's immune system to target the way that tumors are treated. CRISPR is a technique which it's a gene editing technique, or sort of a genetic engineering technique, if you will, that uses small pieces of DNA or RNA to cause edits into the system and be able to target specific cells. So it's one of the hot topics within immunotherapy, and using the patient's genetic system to work to target specific tumor cells.
So what you're saying is you could, like, for lack of a better term, take out some of my blood, get my DNA, and turn my DNA by genetically altering it, turn it back into a warrior to go in and get rid of my tumor?
Yeah, I think that this has been something that as we move more to more personalized medicine. So for example, not just using a tool like chemotherapy, for example, traditional chemotherapy affects all cells, right? But if we can understand more things about your specific tumor, maybe some tumor signatures that are within your blood, and tailor the treatment so that they only attack the tumor cells themselves, that would be amazing, right? And that's I think, several years back that sounded like a pipeline dream, but I think that as scientists, for example, like Dr. Lathia, and for example, our group partnering with people like this, so taking tumor tissue and maybe blood from patients who have given their consent for us to study their tumors in more detail, and then having scientists really look at this. We're getting closer and closer to realities where we're going to be able to do this for hopefully most tumors that people have.
It was really important for me to be part of your clinical trials. So yeah, I donated my tumor. I don't know what you ended up doing with it. I'm hoping it went to this particular research. But you are also doing something with AI. Can you talk about your particular research, what it is, what you're doing, and what you hope to accomplish?
Sure. So our AI, or artificial intelligence, is one of those other hot topics that everybody is looking at. So, harnessing artificial intelligence to answer certain questions. In our case, one of the things that I think it'd be helpful up front, is to understand as much as we can about the tumor, even before we go in and do surgery or radiation on a tumor. So in meningiomas, for example, we know that most of them are benign. A smaller chunk of them are atypical or a little bit more aggressive behaving, and a very small set are cancers. Wouldn't it be nice if we could know all of that information without having had to open somebody's head up and get the tissue? And perhaps would that change the way that we would treat that patient? Would we look at the role of surgery and radiation or timing of those things in the same way that we do today? I think the obvious answer is probably no. The more information that we have about a tumor ahead of time, we will use the tools that we currently have, and perhaps develop some new tools to treat that a little bit differently than we would have ahead of time. Where AI comes in, for example, with meningiomas, is in predicting some of those aspects. So can we put in all of these radiological aspects that we know are associated with higher grade tumors or more aggressive tumors, swelling around the brain, some different signal characteristics on the MRI scan, and at least come up with better probabilities of understanding? Or maybe instead of it being just we have a 70% chance that we know the answer here, can we get up to 90, 95 or higher percentage that we know more and more information about those tumors? That requires us to have a large library of patients who have had tumors like you, right? And have their tumor tissue and have the information about what their imaging characteristics looked like and what their clinical course was and what their pathology showed. And then putting all that information and using the power of artificial intelligence to now look at that in a more predictive way.
From the research standpoint,
Mm-hmm.
how soon? I mean, because how much has changed in the last decade or even 20 years? From my perspective, it doesn't seem like much has changed, especially relating to brain tumors. I remember covering when gamma knife surgery started, or,
Mm-hmm.
So what do you see on the horizon? What's the next new best thing?
I think, so perhaps I see it a little bit differently, because when I was in medical school, I remember learning about brain tumors in one way. And take glioblastoma as an example. Glioblastoma is a brain cancer. The way it was diagnosed is literally by the pathologist looking under the microscope and doing some special stains. And based on these collection of patterns, they would make a diagnosis of glioblastoma. That tumor is not diagnosed that way anymore. In fact, some of the genetic changes are a part of the World Health Organization criteria and how to differentiate some of those tumors, some gliomas versus a more aggressive variant, as a glioblastoma, for example. Within meningiomas, we're just on the cusp of that right now. We have been at a point where the diagnosis is purely made based on patterns that are seen under a microscope. But now there are genetic changes that are being better understood that are going to be part of the next update on World Health Organization guidelines. So, and that will help us predict their behavior even better than we are today. So I think that that's one of those things that's on the horizon. But with harnessing, for example, whether it's artificial intelligence for understanding imaging characteristics better, whether it's techniques like CRISPR and genetic engineering on how to target cells more specifically, I think that this is about the most exciting time that there's been, in recent memory, in combining technology, science, and the ability to treat patients with brain tumors in the best way.
Since we're still in the midst of a pandemic, has the pandemic impacted you, or how treatments have gone, because it was difficult for people to get into a hospital, and where are things now, or what have you learned from it?
Yeah, I think there's no question the pandemic affected all of us, right? With brain tumors, generally speaking, patients with brain tumors that had symptoms, at least in our state, in Ohio, fell into the category of folks that could and should be treated sooner, regardless. There were some scary times, though. For example, with the procedures that we do through the nose, that was one of the highest risk procedures, because it was thought that when you go in and you stir things up in the nasal passageway, that there's a lot of viral particles, and some initial reports were coming out, actually out of China, that 15 people may have been infected in the operating room, that where somebody had this procedure, and that scared everyone. But then later on, it was found that actually only 2 of those people were actually in the operating room, and many of those other people didn't have proper personal protective equipment when they were interacting with the patient. So one of the things that we learned in dealing with that pandemic was that you still have to come down to the scientific rigor and questioning each situation, because something which sounds like it makes sense can be just a sensationalist thing that spreads like wildfire and scares everybody, and may prevent people from even getting a particular procedure because they think it's at incredibly high risk, when the reality may not be as it seems initially. I mean, we still treated patients with brain tumors during the pandemic. They weren't particularly ones that were more aggressive behaving. They couldn't wait. It wasn't like you were getting your knee replaced and you can still get around and maybe just wait a little while longer. But we did have to adapt and learn about things that were outside of our field in a quick manner to determine how to still care for patients within our own field.
So the telehealth appointments are going to stay.
Thank you for bringing that up. Yes, I didn't even touch on that. Telehealth for brain tumors is wonderful. There are so many things that we can evaluate about how a patient functions by seeing them, by seeing how they smile, how they close their eyes, how they're able to stick their tongue out, how they're able to walk around without them stepping foot in the office. It also increased access. For a period of time, if somebody was in the Upper Peninsula of Michigan and they had been diagnosed with a brain tumor, they had immediate access to somebody who does this type of tumor all the time. This is also going to be something that I think our state and our federal governments are going to have to take a look at, because for an evaluation like that was not permitted legally as a new patient via telehealth. And during the pandemic, that was suspended. Those limitations were suspended. Now we've sort of reverted back, like, okay, if I'm not licensed to practice in Michigan, I can't see a or Montana. I can't see any patients from there. But I do think that some of our laws are going to need updating, right? Because telehealth has certainly increased access, or has the ability to increase access to patients who need care in like patients with brain tumors, without having to travel 700 miles for just a 30-minute visit to find out that we're going to watch.
I know from my perspective, even before the pandemic happened, it was critical for me when I was undergoing some pretty severe swelling, and I was just able to hold my phone up and FaceTime with your nurse, and she was able to see me and decide, yes, you need to come in, or no, you don't. And just that simple of a, literally a 2-minute FaceTime was so valuable, and calming, where she was able to see it, and she was able to say, no, that's normal, or, in my case, it was fine. I didn't have to run downtown to go see you.
One of the funny things related to telehealth, and something that I think particularly patients with brain tumors would think, is, if I don't see my doctor in person, like, how am I going to establish this relationship? The funny thing is, when patients saw us via telehealth, they were seeing our face. They were seeing our emotions. Empathy is much easier to communicate when you're seeing somebody's, whole face. And ironically, in the clinic, we were all masked, and it's a little bit harder to communicate some of those emotions if all you're seeing is somebody's eyes. So things that we initially thought were impossible to make a meaningful relationship ended up being completely possible, nonetheless. So,
why should the average person care about brain health and brain tumors?
I think caring about their brain health and caring about brain tumors is, brain health overall is super important. It's who we are as a person. It's one of the biggest differences in my field versus some of the other fields. If you have a bad knee, then it's harder for you to get around, but fundamentally you're the same person. If you have a problem in your brain space, and it's affecting critical neurological functions, that can potentially impact who you are as a person, or how you really experience life. If you can't see, if you can't, if you're not remembering things appropriately, and to know that yes, brain tumors can certainly be one of those causes, but there can also be big wins and improvements in quality of life if they're addressed. And of course, if they're not addressed, a progressive worsening in quality of life.
Well, I can attest to my brain tumor made me a much more grateful person, that I live in a town that I had such amazing access to healthcare and really experienced surgeons. We talked a little bit about, obviously be careful when you go to the internet, but at the end of this, I always want to say there are websites people should go to that has legitimate information. So there's no way in health you want to Google just anything. If you had a website, where would you direct people?
So for brain tumors, a natural starter is the American Brain Tumor Association. They have really a lot of high quality, reliable information on a great variety of brain tumors. I think that other institutions, for example, like the Cleveland Clinic, has a lot of educational resources. The Mayo Clinic does too. I think institutions that are reputable are a good place to start. I would be very careful, starting in just with a single person who you don't know, and starting with their experience and basing all of your information and decisions based on the interaction. Well, I think it's good and important for people to be connected and people to have others to lean on make sure that that's placed in proper context with reputable sources, and also with assistance of your physicians who have expertise in that area.
And from personal experience, I can't agree with you more. Dr. Pablo Recinos, thank you so much for being part of this. This was really, really educational, informative, and valuable.
Thanks so much for having me, Monica.
Please find me on Twitter and Instagram at Monica Robbins. Catch up on health news and future podcasts on my Facebook page, Monica Robbins WKYC. Video podcasts are uploaded to my YouTube channel. Just search Monica Robbins and please subscribe too. Keep up to date on all of your news, sports, and weather on WKYC.com and the WKYC YouTube channel, and please follow the WKYC social media accounts as well. Random acts of kindness are good for your soul. Practice them daily. I'm Monica Robbins. Until next time, have a healthy week.
Thanks for listening to Health Yeah with Monica Robbins from WKYC Studios. Subscribe now so you never miss an update. And find more on everything you heard here on WKYC.com and on the WKYC app.